Hello, everyone. Thanks for joining the webinar. I was just getting the lowdown from Matt at CFN as to how to run this, so I'm really hoping that I can not mess up my part. Just before I forget and I start my presentation, just a reminder, if you have questions, to please type them into the question box on the right-hand corner down below in your control panel for the webinar in your app. And when the presentation's over, and there should be about 15 minutes for discussion at the end, I can read the questions out and answer them. Now, my understanding is that you guys can't speak into the microphone because you are on mute, so I am hoping that you can all hear me and we can start this. Okay, so my name is Amy Can. I am an associate professor in the Department of Family Medicine at the University of Calgary, and I am part of the primary care team within the larger iCAN-ACP project, and I wanted to thank my co-authors in this specific presentation, Carly Patterson, who's the research assistant working with me in Calgary, who's on the line and will be helping me with answering questions if needed, and Michelle Howard, who is the team lead for the primary care arm, who's also on the line, I believe. I just wanted to acknowledge that this is work that is funded by the Transformative Grant from the CFN as part of the larger iCAN-ACP project. And the objectives of today's presentation is to describe how the primary care team developed and implemented an advanced care planning pathway within family medicine and primary care for the iCAN-ACP project, which utilizes specific tools from our previous IGAP work and uses specifically the serious illness conversation guide in the pathway. And then I will be showing you outcomes that we have from the feasibility pilot of using the pathway in the Sunridge Family Medicine Teaching Clinic in Calgary, where I am one of the physicians. And we were able to get feedback from both patients and surrogate decision makers, as well as the clinician participants. So most of you are well aware of the vision and mission of the larger iCAN-ACP project, where the project is called Improving Advanced Care Planning for Frail Elderly Canadians. And the vision for frail elderly Canadians to receive patient-centered, goal-consistent care at the end, near the end of life is essentially our vision and our raison d'etre. And we have the mission to increase uptake, impact, and access to advanced care planning for frail elderly Canadians across different healthcare sectors, namely primary care, long-term care, and the hospital setting. This is the family medicine and primary care team. So I see some of you are on the line. Thank you. But this really shows that it is across the country that we have different provinces involved, and we have practices in Calgary, Brampton, Ontario, and New West in BC that are going to be part of the cohort phase for which this pilot was helping to prepare our work for, and our research team across the country as well. So we're using Rebecca Sidori and the consensus definition of the Delphi process consensus statement with regards to advanced care planning. And we're using this definition really to help patients and surrogate decision makers understand when we try to recruit them as to what we are hoping to help them through, in that it is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences with regards to future medical care. So really assuring them that they're not making any healthcare decisions for today, but for preparing themselves for the future, with the goal to help ensure that ultimately patients and people in the public receive medical care that's consistent with their values, goals, and preferences during serious and chronic illness. And the chronic illness really pertains, I think, to the family medicine milieu that we deal with our population, in terms of trying to convince both family physicians and members of our patient population that this is timely and relevant. So why advanced care planning in family medicine? I really believe, I personally believe as a family doctor that helping patients to have conversations about advanced care planning and goals of care discussions is really what we do in family medicine with regards to patient-centered shared decision-making, and that's really the central tenet to family medicine. And the hypothesis is that the longitudinal relationship in family medicine creates an ideal setting to facilitate advanced care planning. However, we know from work in the literature and in our previous work with the iGAP team that there are barriers to advanced care planning. There's barriers from the public perspective and patient's perspective, and there's barriers from the healthcare provider or family doctor's perspective. I could spend an hour just talking about the barriers that we've elicited, but the short snapper is that there's a perceived lack of time, primarily from the family physicians, and thinking that they're opening up Pandora's box and how do they actually contain this within fee-for-service milieu that we all work in. But then also that there might be some uncertainty with these conversation skills from the family physician perspective, uncertainty with disease and illness trajectories as well. So what we were hoping to do with the this transformative grant project was building on the previous iGAP work that we had, was looking at how do we perhaps capitalize on the team-based approach that family medicine in Canada is really working towards, and listening to some of the barriers both from the patient side and the physician side in terms of preparing patients to think about some of these topics before discussing with the family doctor. Could we do some pre-work with the patients and surrogate decision makers, utilize and maximize the scope of practice for our allied health professionals in family medicine to then be able to have fruitful, effective, and efficient conversations with the family doctors after patients have done some of this pre-work. So that was kind of our thought about developing and implementing this pathway. So this just shows you essentially where iCAN-ACP as a larger team is looking at focusing earlier on in and upstream in a patient's illness trajectory about advanced care planning and not leaving it to the end of life. And I would argue that in family medicine, perhaps we are really dealing with, the first half of this oval as well, where we're really looking at patients who are outpatients, who are living their lives out in the community, and they are utilizing family medicine services. Perhaps they have chronic diseases, but that they might have had an early diagnosis of serious illness, but they're somewhere earlier and more upstream in their chronic illness or their serious illness. So I mentioned in the objectives that we are using the Serious Illness Conversation Guide to provide some structure to this pathway that we are developing and implementing and then ultimately testing in the cohort phase. And this is just a schematic from Alberta Health Services. Jessica Simon, part of the iCAN team, and myself, we, with our AHS hats, helped to teach Serious Illness Conversation Guide in Alberta locally, but really just to conceptualize how Serious Illness Conversation Guide could actually act as a link between the larger advanced care planning and the very specific goals of care decision-making. In the province of Alberta, the goals of care decision-making actually is an order form that I will be mentioning later on in the presentation, but really it's about specific decisions as they come about in terms of needing to be made. So in a nutshell, we developed a pathway that was housed within family medicine, where first of all, we trained the physicians and allied health in the serious illness conversation. We actually worked with the Ariadne Lab group, Rochelle Bernacki and Joe Palladino and others last year to get their blessing to perhaps test how to do the Serious Illness Conversation Guide in a different order that might be more approachable in the family medicine population that is a more well population. And I will detail that in a later slide. But essentially, we did train the physicians and the allied health professionals in the Serious Illness Conversation Guide, and then we implemented a pathway in 3 parts for the purpose of this study. So in the first part, there is education with regards to advanced care planning and surrogate decision-making using some of the tools that were tested in our previous IGAP work. So the Alberta-centric Conversation Matters Guide, which is very similar to the National Speak Up campaign materials, and also some specific education about how to choose the right surrogate decision maker or substitute decision maker. This was done in conjunction with the consent and demographics with our research assistant, Carly. The second visit, once that was done, invited both the patient and the substitute decision maker to come in for what we call visit 2, where there were specific tools that were utilized in a facilitated manner, namely the best worst scale tool, and the values questions of the Serious Illness Conversation, then documentation of the values conversation in both a Dear Doctor letter and the tracking record that is part of the Alberta Health Services documentation requirements. And then the last visit is with the physician, the family physician in the clinic, where they complete the rest of the documents for the green sleeve in Alberta, but really it was about discussing the values and priorities that were elicited and clarified between the patient and the surrogate decision maker with the help and facilitation of the allied health provider, and how that could translate to specific goals of care designation and possible potential future medical decisions that would need to be made based on the individual health context of the individual patient in front of the family physician at any time. So this is just another way to show what we did in a simplified manner. We identified patients, which I will detail. They had the RA visit with the pre-ACP tools and education about the surrogate decision maker. There was some training that we did, and then the visits with both either the RA or the allied health professional as we rolled it out, ideally with the surrogate decision maker in attendance. These documents were then sent to the family physician in their electronic medical record for review prior to the family physician meeting with the patient, and then there was a visit 3 with the patient. And then that's after the 3 visits were done, we collected the pilot feasibility data. So when we were developing and implementing this, we really thought that we really needed to test this in real life and make sure that this was feasible, acceptable, and made sense from a clinical perspective in a real life family medicine practice. And lucky for us, my clinic, Sunridge Family Medicine Teaching Clinic in Calgary, was very collaborative and helpful in playing ball and being guinea pigs for us. And were very helpful in helping to iron out the processes before we rolled it out over 3 provinces for the cohort phase. And so that's how this presentation, for which the pilot phase is focused on, how this all came about. We really felt like we needed to test it. There seemed like there were a lot of moving parts, and we really wanted to have the process tested in a meaningful manner so we could be more confident for the cohort phase. And then ultimately this would then inform what we were doing for the cohort phase. So the Sunridge Family Medicine Teaching Clinic, just to give you some context for the setting for the pilot, is one of 3 full-time academic teaching clinics within the Department of Family Medicine at the Cummings School of Medicine. So that means that we as clinicians, there's 16 of us who are part-time academic practices who see medical students, residents full-time and teach full-time while we're seeing patients. We are in a very socially diverse area, a town by the airport in Northeast Calgary, and we have a large variety with regards to socioeconomic status in terms of patients. We have a large immigrant population in our neighborhood, and we are one of 4 clinics in Calgary that took on the publicly sponsored Syrian refugees during the surge a couple of years ago. So that just gives you context as to kind of the patient population that we are privileged to serve. We're also part of the Mosaic Primary Care Network, which in Alberta is a conglomeration of several family medicine clinics within a geographical area in a city, and we have government funding to use pooled allied health and primary care initiative funding to optimize the team-based approach and comprehensive care to the patients in our population. So that means we have access to social workers and dietitians and chronic disease management nurses and respiratory techs and pharmacists and lots of other people that we're super grateful to have in our team to be able to best meet the increasingly complicated and comorbid population that is family medicine. And we also, because we're a teaching clinic, we also have Alberta Health Services resources. So I'm going to go back to the pathway just to kind of walk you through the pathway as to how we developed the different parts, the different boxes that make up the pathway. So the first part was the patient identification, and using a variety of sources that were in our in the literature and part of previous work that other team members had done, we were looking at essentially the WHO cutoff for elderly, which is 60, and then how do we actually define frailty and identify frailty within different family medicine practices. So we looked at things such as age, polypharmacy, whether or not they needed home care services, whether or not they had unexplained or unplanned emerge visits or hospitalizations, whether or not there was caregiver concerns about a patient not thriving in the community, and also modified the surprise question for the surprise question being, would you be surprised if your patient were to pass away within the next year, to would you be surprised if this patient were to require an unplanned hospital admission or acute care services in an urgent manner in the next 1 or 2 years. So again, trying to bring the umbrella out a little bit with regards to family medicine, primary care population. Other thing we looked at, which we found helpful for family physicians to kind of get a gestalt of their patients as they're looking through their list of patients 60 and over with comorbidities, is to look at the Canadian or the Rockwood Clinical Frailty Scale, which is a made in Canada scale. And really, this really, I think, helped the family doctors visualize their patients and how frail or vulnerable one may be. So we really targeted the CFS scale from 4 to 6, but also included people who were perhaps a little bit more well and perhaps even more frail, depending on the assessed need by the physician. Another way to look at this, or have the family physicians look at who would be amenable for this project, was to say, everybody eventually in the family medicine office should have advanced care planning done, whether or not we may focus on different parts of advanced care planning depending on how well a person is or how well functioning a person is. And this is probably our utopian state, but we're really looking at those with chronic disease, with decreasing health, decreasing functioning, and increasing frailty. So this is another way to kind of superimpose what they're looking at with regards to their patients and their population and the clinical frailty scale. We started with Carly, the research assistant, being in the clinic and asking the family doctors who had agreed to participate in our pilot. There were 4 physicians who consented to participate. 3 actually had patients that we could use through the pilot process. We had her sit during the clinics in the clinic and say, hi, just to remind you that if you have anybody over the age of 60 who meet some frailty parameters, to perhaps let me know so I can approach them to be consented. And we found that that was not efficient. And so we started running patient lists with the help of Kathy, our primary care nurse, and really our liaison with the Sunridge Family Medicine team, and looking at running lists of patients over age 60, and then having the family doctors use these parameters to identify patients that then our LPN could call for permission for Carly, the research assistant, to then contact for consent for the pilot because ethics was not allowing us to directly contact these patients. So that's kind of recruitment, what we learned and how we went through recruitment. This is a very busy slide, but this is really just to show, I think most of us are on the call, at least, are familiar with the Serious Illness Conversation Guide. But this is really to show that while we use the conversation guide in its fulsome and kept to the language authentic way, we did talk to Ariadne about flipping the order. So you'll see here after visit 1 with the pre-information with the circuit decision maker education, we actually had the allied health professional do visit 2, and this was really looking at the values questions. And then visit 3 was having the family physician prognosticate with illness trajectories, because that might be more in keeping with the family medicine practice where there is not a known prognosis, i.e. 1 year, etc., because these are patients more with chronic illness. And then getting the family physician to then be able to use the Serious Illness Conversation, the pre-work done with the values and goals clarification that was asked in visit 2, along with the best worst tool, to then close up the visit with documenting the perhaps goals of care designation in Alberta, discussing specific scenarios that were acceptable or not acceptable to patients, and then for the pilot, for the Alberta specific context, to actually complete the goals of care designation Greensleeve documents. And that was actually our kind of carrot in, I guess, consenting both physicians and patients that this would help with getting some of the required paperwork as an Alberta Health Services patient done as well. So just to show you, quickly go over the best worst scenario tool. This was developed by members of the iGAP team, and it was developed after finding that patients, when they were clarifying their goals, perhaps weren't realizing that there were trade-offs to be able to achieve these goals. And so this led to the development of an online tool that makes patients choose the most and least important of different scenarios to help clarify trade-offs. And this actually helped to frame and prepare them for thinking of the values question, specifically the trade-off question in the Serious Illness Conversation Guide, but also all of the questions about strengths and abilities and what are their fears and worries. So this is just an example of the graph that gets resulted after they do the questions. And this was used in the Dear Doctor letter to both frame the conversation with the Serious Illness Conversation Guide that the allied health professional was doing in visit 2, but also help with the documentation that the family physician would then review prior to their visit for visit 3. And this is just a quick look at illness trajectories that was used in the training of family physicians to help them explain, perhaps with those patients who have chronic comorbidities and chronic illnesses such as congestive heart failure and COPD superimposed or renal failure, to help describe both to themselves that unfortunately there is a downward trajectory for chronic diseases that we see in family medicine, but also to help the patient understand that this was a timely exercise, given that with every exacerbation, it was heralding of progression of the disease. So the outcomes after the 3-visit pathway were the completed personal directive, where there was a designation of this circuit decision maker, the Dear Doctor letter that had the best worst table printed out, plus the answers from the values questions from the SICG. Then the allied health professional also documented in point form salient parts of that values-based conversation in the Alberta Health Services tracking record, which is part of the Greensleeve documentation for AHS. And then ultimately with the visit with the physician, they would extend their documentation of their conversation in the tracking record, which lives as a real life dynamic record of ongoing conversations pertinent to event care planning. And then the goals of care designation form that is similar to the most or the post, as we know in different centers. So really, though, the outcome was really to look at refocusing things back on values and conversations, and not just, what is your designation, but actually helping patients go through this fulsome reflection and values clarification to help the physicians then be able to translate and recommend an appropriate goals of care designation based on the values work. So these are just the visuals of the personal directive, the linking of the Dear Doctor letter and the tracking record to the family doctor, and then the family doctor can ultimately, in a more confident way, fill out the goals of care designation form in Alberta. So how did we look at the feasibility of this after this was all developed and implemented? Was we surveyed the patients and surrogate decision makers who consented in visit 1 after they had completed all 3 visits. And we also did follow-up phone calls 2 to 4 weeks after they had finished all 3 visits, just to help with reflecting back on the process and what they found was important, and that would help inform our cohort outcome measures. With regards to the clinicians who were a social worker in our clinic, because there was one social worker who did all of the pilot visits after the initial couple that Carly did to, again, work through the kinks in the process. We did an interview with her, and then we did a focus group with the 3 family physicians who participated in the visit 3s with the patient. So with regards to the results for the pilot phase, we had 9 patients complete the pathway, and we had 8 surveys that were completed. We actually had 10 consents, but 1 was not able to, or decided not to complete the pathways after consenting, with 7 surrogate decision makers, and then we had 3 family physicians and 1 allied health professional. So with regards to the patient demographics of those who consented, you'll see here that we had a good range of ages from 61 to 82, an average age of almost 70. 1 had actually consented and filled out the consent form but didn't give an age. We had mostly females, but a couple of males, none of them actually identified as non-binary. All of our patients did identify as heterosexual, but you can see that there was a variety with regards to marital status. And there was a variety with regards to education, in that some had completed high school, some had some college or post-secondary certificate or diploma courses, some had trades, and then 1 had a higher than bachelor's degree. All were born in Canada except for 1 who was born in the Philippines. With regards to the surrogate decision makers that the patients ultimately chose as part of the intervention and who chose to consent to our process, you'll see a wider range, which seems to make sense with the surrogate decision maker population. So we had age 31 to 77, a slightly younger age average. Again, more females than males, but at least we had both. None were non-binary, all were identified as heterosexual. And so mostly married, a couple divorced, and then again, a wide range of education, same kind of demographics for born in Canada versus the 1 that was born in the Philippines, and that was the same diet. And I thought it was interesting to put here that half of the surrogate decision makers lived with the patient and 50% did not. So when we surveyed our patients about, after completing the 3 visits, what they thought of the process to help us with feasibility, we asked how well they felt that they understood event care planning after all 3 visits and completing the pathway. And you can see everybody, 100% actually positively agreed that they did understand ACP well. The 4 out of 5 just meant that that was on the Likert scale, that's what they chose. With regards to whether or not it's appropriate to do in a family physician's office, which I think we still need to prove to the community, the larger community, that this is appropriate. All patients found it appropriate or absolutely appropriate. And they thought that the time it took to go through the 3 visits and the pathway was just right for what they were trying to do. And they thought it was very good use of the time. Now, interestingly, some of them did think that having had the conversations, that it did make them moderately upset. But when you looked at the rest of their, even the ones who mentioned that they were moderately upset by having to have these conversations, they rated the entire process very strongly. So it wasn't that it was a deterrent. It didn't appear to be a deterrent to actually having to do the work and go through the process. Excuse me, sorry. And then in terms of trying to tease out, was visit 2 helpful and visit 3 helpful? Both seemed to be positively rated, in that after visit 2, they felt that they were either somewhat to extremely ready to talk to their family physician. And then after their family physician visit 3 and finishing the pathway, they felt quite prepared, to extremely prepared to do ACP or think about ACP going forward, and thinking that they had done the groundwork needed. And they overall were highly rating of the advanced care process in general in the family physician office. Some comments that they made, that it was an excellent process and that should be a standard process for all family doctors, regardless of age, to follow. It was important for me to have this done while thinking is clear and inform my family of wishes. They felt it was done professionally with great compassion and care, and so there's a good process, probably needs revisiting if health changes, and some people wanted to still reflect on it further. But I think what this shows is, A, it was positively received by patients. They found that this was worthwhile. But I think it also shows some of the education was sinking in terms of, that it was important that they do this while their thinking was clear. It was important that their family be involved, and that it needed revisiting and ongoing reflection. With regards to the surrogate decision makers who were surveyed and who answered our survey, again, similar questions to the patients. We asked them how well they understood it after their visits. Now, this was after visit 3 of all patients, but I did not tease out how many of them attended visit 2 versus visit 3, or both, or none. So this is having supported their loved one through the process in general. So this doesn't delineate which visits they were part of, although their comments may actually say some more details about that. But again, they found that it was absolutely appropriate to offer in a family doctor's office. None of them actually were emotionally upset by this process. And how ready do you feel to talk about your loved one's wishes with their family physician went from somewhat, which is 3 out of 5, to extremely. So while we didn't do pre-survey, we found that this, at least the outcome measure of having done this survey, was that they felt prepared or ready to actually do surrogate decision making. And how prepared did they feel? They felt quite prepared to extremely prepared to carry out their loved one's wishes. And they were, again, very supportive of doing this process in the family doctor's office. The surrogate decision makers' comments really showed again that they recognized the value of a formalized process over a period of time to allow processing and reflection of thoughts and feelings. I thought that it was great that surrogate decision makers thought it was an absolute essential activity to take or do. This must step to cater to the needs of the patient. And patients also, surrogate decision makers also started thinking about whether or not they should be doing this for themselves as well. So to help us with our outcome measures in our cohort phase, we also followed up with the patients and surrogate decision makers that we could 2 to 4 weeks after the intervention, to allow them to have had time to reflect on their experience. And we asked them, after having gone through this process in the clinic, what do you expect to change going forward? And in general, they thought there was a heightened awareness about advanced care planning and that they felt more prepared for the future, and that there was a comfort in having things discussed and documented with both their loved ones and their surrogate decision maker and their family physician. The most important aspect of the intervention from the patient's perspective was assigning a surrogate decision maker and having the surrogate decision maker involved in the process. And they felt that the discussion with the Serious Illness Conversation Guide, they didn't know it was a Serious Illness Conversation Guide, but the discussions that were had with the visits and the best worst scale helped to clarify their wishes so that they were known and understood by the healthcare team. And they weren't, none of the 8 patients surveyed by phone after were able to identify anything that was less important, because they found that the whole process was important to them. We asked similar questions to the surrogate decision makers. We only were able to contact 2 in the longer term follow-up, but they felt more prepared for their role as surrogate decision maker. And interestingly, the surrogate decision makers found that attending the visits was very good use of their time and important for them to be part of the process. And again, they weren't able to identify a less important part that should be removed. And again, they made the comment that they were now thinking of ACP for themselves. So that was the patient and surrogate decision making perspective. And now these are the family physician and allied health professionals perspective. So again, our numbers were small. This was a pilot, but I just wanted to show you some of the key points that came out of our focus group transcript and our interview transcript with the physicians and the social worker involved. You can see that we had 2 female family physicians and 1 male, and a range from 4 years in practice to 30+ years in practice, and a social worker with 5 years of clinical experience. So for the social worker, she really thought the training was important in terms of having a new language and structure. With regards to the process, she was able to compare this to her previous work, where she had been doing goals of care designation discussions on referral by the family physicians in the clinic, and she found that before there was no process, so there was unclear expectations as to what was within her scope and the physician's scope. So she really appreciated that there was a new process with role clarity, and the script allowed her to have confidence in being able to discuss values and relating that to the goals of care with patients. It took pressure off of her to have to actually recommend a goals of care designation, because that was clearly delineated as the MD role in this. And she found that the process was both manageable and understandable from both perspectives of the patients that she was working with, and the surrogate decision makers, and the allied health professionals. And based on our experience of doing advanced care planning in our clinic before this process, and now with this process, she had some good logistical recommendations for future sustainability once this was not within the purview of a research project with a research assistant supporting it. She found that the content was useful, specifically the best worst scale seemed to resonate with the patients. The quote I have from her is, "It turns into this lovely graph and it resonates with people. I think it's not the same. It got the person in the frame of mind for these kinds of questions that were coming." With regards to the Serious Illness Conversation Guide, she said that the flow as designed worked really well. It was a very natural flow, and the patients were not necessarily aware that I was using this guide. And she does recommend ongoing involvement of the surrogate decision maker in her visit, which was the visit 2. It took about 60 minutes to do this part of the structured pathway. And again, she had some logistical feedback about the process for our cohort phase. With regards to the family physicians and their focus group that they reflected on the process, they thought the training was great. It was good that they actually had to do the role playing to actually practice the language. So when it came to patients, they had gone through that awkward stage of learning new language. They did want more training with illness trajectories and prognostication, and I think that's not a surprise to any of us in medicine. That's one part of medicine that we just don't feel confident about. The family physicians also identified that really they thought housing it within family medicine utilized the continuity of relationship in family medicine, and this helped to have these types of conversations with patients more as an overall observation, and that the pathway could definitely change their practice, but would need multidisciplinary team in place to support family physicians. So they really supported the pre-work and the values clarification that was done with the allied health professional before they did their visit. The length of time for most of the MDs was about 30 minutes on their recollection. So we didn't time them, but this was what their perception was, that it was 30 minutes. And again, they had some logistical feedback as well to help us with our processes. What I wanted to show you was with regards to their process feedback, they found that their eligibility criteria was too exclusive. So they're too exclusive in that they wanted patients who might have been younger than 60 who had frailty measures or who had comorbidity. So they were actually wanting larger parts of their population to be involved. They found that the order of the pathway was beneficial. Quote, I'm more confident that I had a fairly clear understanding of what their goals were before we entered the discussion, whereas in the past that had been fairly vague. So because the first thing you do is clarify that those are the right goals, and so even though yours weren't accurate, it still even though yours weren't accurate, it still provided an entry into the conversation that we hadn't had before. So the sequencing worked really nicely for me. So this was a family physician who actually said that reflecting the goals, the patient actually changed some of her values during visit 3, but even with the change, the discussion and having had that context was still helpful. They thought by and large their patients and loved ones found this process helpful. A quote, my patients and the substitute decision maker felt that without fail, it was a really helpful and productive process. And having the surrogate decision maker involved improved the discussions. Another quote, I could tell the difference between the meetings where the substitute decision maker had not been part of the initial conversation and were just coming in for this part. So if I had any suggestion with that, I would be strongly encouraging people to bring their SDMs to both sessions. With regards to the content, they found that the values elicitation with the serious illness conversation guide prior to their visit really provided clarity and helped them. And so the content of the earlier visits really primed and prepared patients to actually then be able to talk about their values and goals and come up with a translation and recommendation for goals of care. And they found both the best worst scale and the use of the SICG to be helpful. One, because it helped the patients sort out and clarify goals within themselves, but also the serious illness conversation guide gave a structure to help them with the processing of these types of questions and help the physician, him or herself, with giving structure as well. So what did we learn through this pilot? Well, first thing I think we learned was that clinic partnership and engagement is key. So thank you again to the Sunridge team, some of whom I think are on the line, because having ongoing conversations about what could work and how could we utilize such a pathway and implement such a pathway in the clinic was really important to be doing in a give and take and ongoing collaborative manner. Having a strong research assistant to help with the direct patient communication at the outset to smooth out the kinks in the pathway was really helpful, because the whole process of mapping had a lot of moving parts, and so it was good to be able to pilot this in real life to make sure that things worked. The training of the allied health professionals and MDs was important, and sticking to the role plays, and the training provided by the community practice by SICGs that we used as a framework for the training was really helpful. And we learned a lot about how to do recruitment more efficiently, and also how to help our family physicians think about their practice and who could be involved. We did learn that having the family physician actually pre-screen and identify the clinical frailty scale during the pre-screening phase, and then also after the visit 3 was helpful. So we're going to implement that in our cohort phase. With regards to the outcomes of our pilot, we sought out to look at the feasibility, acceptability, and clinical sensibility, and we found that the pathway was feasible for all those involved. And it was definitely acceptable from the patient and SDM perspective, in that they found it was important for their healthcare and it was valuable use of their time. And that the outcomes of having the discussion and documentation helped them feel more prepared and kept them thinking about this even 2 to 4 weeks out. The clinicians found that the pathway was helpful because they found that it prepared patients for having the more specific healthcare context conversations with them in visit 3, but it also provided them with language, with the Serious Illness Conversation Guide, with language and tools to be able to use to help with their communication of these types of topics. All parties involved thought that involving the surrogate decision makers as much as could be possible for this SDMs was really important. And we have ongoing work with long-term sustainability and how this could help with concordance and decision-making down the road, for which we're trying to tease out for our cohort phase. So in summary, this pilot was really useful in working out the areas that need to be worked through for a real life pilot to then be able to be spread out to other parts of the province, but also for us to have more confidence in the pathway that it was acceptable and feasible for the participants involved. The structure was helpful, both in terms of the visit pathways and the structure within the visits for both patients and surrogate decision makers who had the work of clarifying values, but also for the health providers who had to help patients elicit these different designations and how it pertains to their values. And hopefully this pathway does help with ongoing communication and documentation so that we can then improve events for planning and ultimately care for all patients in all healthcare sectors. So thank you again to the Sunridge Family Medicine Teaching Clinic team for their help in developing and implementing this pathway. And again, for being so approachable to all the little things that we needed to tweak as we went through it. And again, thank you to the Ariadne Labs group, because they, again, gave their blessing for us turning the order of the SICG around to see if it would be amenable in a family medicine practice. So we have about 10 minutes for questions. And I'm just going to open up the question thing. Nobody has typed a question, so I don't know if anybody has any questions or comments. Somebody, I'm not sure how to use this, but somebody has. And Matt, maybe I can ask for your help in seeing if I'm missing anything, please.
Hi, Amy. I just opened up. Oh, one just popped up, actually.
Okay.
I think there's a couple there now.
I'm not seeing them. Let me see. Oh, there we go. Okay. The flip method of SICG, can you elaborate? Sorry. Okay. What were the health conditions of the pilot participants? So because of ethics, we did not get the formal diagnosis from the healthcare provider, but when we asked for their demographics, the patients self-reported a clinical frailty scale of from 1 to 6. The majority actually were clustered in the 1 to 2, but we found that they didn't correlate with the physician's clinical frailty scale, which is why we are implementing this next step in the cohort phase. And they had everything, well, they had COPD and CHS and renal failure, and so very bread and butter family medicine comorbidities. One was a cancer patient with a undetermined prognosis because she had thought that she was palliative, but actually has gone on to do quite well years later. So that's the first question. Another question is, how did you come to decide to use the flip method of the SICG? Good question. So we, in discussing kind of how we were going to use the Serious Illness Conversation Guide, in prior discussions and also during the training that I had had and other members like Michelle had had in Boston with the SICG, it was loud and clear that every member of the healthcare team thought it was the role of the physician to prognosticate. And we found that prognostication really was required to do the medical context questions. So we went out on a limb and thought, well, could the pre-work that family doctors are telling us loud and clear that they want to be done prior to the physician visit and to maximize team-based care for patients in family medicine, could the values questions be done without prognostication and the healthcare context? And could it be done by an allied health professional? So that was really our hypothesis going forward, was how do we remove the prognostication, but then still be able to do the values clarification before a physician starts talking about prognostication, illness trajectories, and the individual health context. And when I presented this to the Ariadne group a year ago, this was a question, and it was discussed that the Serious Illness Conversation Guide was really written with the palliative care patient in mind, and so that's where prognosis and limited prognosis, they found, really need to be front and center to be able to frame all the other questions. However, in a family medicine practice where they might be earlier in their illness trajectory or not have a limited time prognosis, but have more of a chronic disease illness trajectory, part of our hypothesis was, could we actually not do the prognostication right off the bat? So that was kind of the rationale for trying the flip method. Was some of it was pragmatic and some of it was philosophical with regards to our population. And then can you elaborate on the best worst scenario online tool and its availability to other areas? What was the approximate time period between each clinic visit? Okay, so this is a three-parter. So the approximate clinic time period between each clinic visit, between visit 1 and 2, because the availability of the research assistant and the social worker was easier to obtain, usually was within a week or two. And then, but most people were finished all 3 visits within a 6 to 8 week period. It depended if the physician was away, etc., but it was done within a fairly compact time period. With regards to the elaboration on the best worst scenario tool, so this is really a tool that, if there was a way for Michelle to speak, I could help defer, but Michelle worked on this with other members, other colleagues, and it's an online tool that is housed on a server at UBC, so I'm not sure how openly available it is at this time. I'm not sure, Michelle, if you can comment on that even through the text, or if I could follow up with you, Sarah Lau, at a later time about that. But essentially, it's very similar to personality tests or leadership quality tests like the Myers-Briggs, where they repeated certain things like a time with, whether or not they wanted life support machines, if they wanted their independence, if they wanted to think clearly. And they pitted those things repeatedly against each other, but you still had to just choose the most important and the least important. And after doing that 7 times, and we used the 7 scale one because it had religious context and relationships, which we also thought was appropriate for the more well population in family medicine. But once the patients were forced to do that and really constrain which one they found was most important and least important, it came out with that graph. Thank you, Patrick. So another question is from John. How much flexibility will other sites in BC have to modify processes when they implement in their local practice? Seems that local engagement input of your colleagues into final design pathway is super important. Yeah, so I agree that having such a great partner in our clinic team was key to our success. I think part of the pilot process, though, was to say this does work in a allied health team-supported family medicine practice, and so we could use this as a framework to then tweak it based on this. So in speaking with the BC team, there's a couple of things that are very specific to the BC team that the family physician could weigh in on, but this could be used as a framework, and this has been presented actually to the physician lead in BC who thought that this was amenable, and again, to be able to tweak certain things. And we actually are in the process of changing who does visit 2 versus visit 3. So it's really a framework, and then who the players are, I think, could be up to the individual clinic and the resources that they have. I hope that answers your question, John. And then Michelle just wrote that the best worst scale tool is in a research platform currently as we trial and collect data. And hopefully, if there's interest, it'll be more available. Okay. Any other questions? So Sarah just was following up, and maybe Sarah, offline, I can connect you with Michelle to talk about this more. Oh, I think. Okay. Okay. Any other questions? If not, thank you so much for listening to me speak for an hour. And thank you again to everybody that I thanked in the project, the primary healthcare team, the clinic. I don't know, Michelle or Carly, if you have any last words, being the co-authors of this presentation, but again, thank you. I'm just representing the work of our team here.